Well, good afternoon, everybody. Thank you for joining us. My name is Jake Lewis. I'm a Senior Community Relations Manager with NUWAY Alliance. Thank you for those joining here in the room, and then also thank you to those joining virtually. We're really glad to have you here to hear Ken Roberts present on the co-occurring ABCs. I just want to go over a few housekeeping items before we begin. For those of you online, it would be great if you could please add your name and email into the chat. That's how you'll receive your CEU credit. They're in the process of being approved right now, so I do have certificates for you here, but I'll send out the final approved one as well. For folks here online, the approval should be in by next week, so you'll get those hopefully by next Wednesday, but I will make sure to give you those. As I said, my name is Jake. I'm thrilled to be on the community relations team at NUWAY Alliance. Thanks to my coworkers, Amy and Jessica and Crystal, fearlessly led by Monique Bourgeois, our Chief Community Relations Officer. I just want to go over NUWAY really quickly. I think it's fascinating. NUWAY started as a nonprofit back in 1967 from a group of individuals at 2118 Alleno Club that saw a need in the community and wanted to do something about it. Lo and behold, here we are in 2024, and there's still a need in the community, and we still really want to be able to help. So, from 1967, when we started as a nonprofit, to now, we have 5 medium-intensity residential programs. There's 3 here in South Minneapolis. NUWAY 1 and 2 serve male-identifying clients, and NUWAY 3 serves female-identifying clients. Then we also have a program in Maplewood, Minnesota called Cochrane Recovery Services, and they have beds for male identifying clients. And then down in Rochester, Minnesota, we have a program called The Gables that serves female identifying clients in the medium intensity residential setting. We also have intensive outpatient with recovery resident support when clinically indicated. We have 7 locations of that program, of that RISE model. So there's 3 here in the Twin Cities. Obviously here at NUWAY University Counseling Center is intensive outpatient with recovery resident support. In Minneapolis, we have 2118 NUWAY Counseling Center and 3Rs NUWAY Counseling Center. And we have programs in Duluth, St. Cloud, Mankato, and Rochester, all doing intensive outpatient with recovery resident support. Rounding off the continuum, we also have an outpatient program that's run in St. Paul here as well. It's ASAM 1.0. And that's a program that has some hybrid availability. There's some groups that meet 100% in person, some 100% virtually, and then also a hybrid option as well. Our most recent addition to the NUWAY Alliance is Aragoni, which is housing support with supplemental services. And just this morning, we sent out an email announcing the open house that we're having on September 18th from 1 to 3. There'll be lots of communication about that. We hope you can join us at Aragoni East in St. Paul. It's on Summit Avenue. Get a chance to see the beautiful location and meet some of the team there. What else do I have on my list? Open house on the 13th. I do want to give YourPath a huge thank you for supporting and kind of doing this joint venture where Dr. DeLisi presented in June. So we're super thrilled to partner with them again. I'm going to introduce Jordan for a quick overview of YourPath, and then he can turn it over to Ken, and we'll get everything started. Thanks, Jordan.
Thanks, Jake. Yes. Good to see everybody. My name is Jordan Hansen. I'm the CEO and one of the co-founders of YourPath. I'm also a person in long-term recovery. Like many of you, I've watched over the past 15 years as our communities have been decimated by the different sort of pieces of this crisis. So when we started YourPath, what we were trying to do is fill the gaps. One of the things I've also noticed during my career is this tension between wisdom traditions and lived experience of people that have found recovery and also evidence-based practices, especially as those relate to the use of medications like buprenorphine. So we're really grateful to partner with NUWAY and with Ken and the team to do this. Dr. DeLisi was able to share a little bit about how we view epigenetics and trauma and some of those pieces in the first portion. I'm excited to learn from Ken on the ABCs, but wanted to share really quickly just a little bit about what we have going on at YourPath. Like I mentioned, we're trying to fill the gaps, and what that looks like is we have all these point solutions. Sometimes people describe it as a system. I don't really think we have a system. I feel like we have these little islands of safety for people, and then we, oftentimes we'll hand somebody a packet and we'll say, hey, go that way, swim through the shark-infested waters. We hope you make it. I think really what I've seen, especially in the past 5 years as we've progressed, is this idea of what does it mean to truly be person-centered? How do we actually match people's clinical presentation to programs that actually serve them in the best way possible. And we built out a technology platform called Sala that tries to tease this all apart, but then bring it back together. Sala allows people to work with multiple groups in a bundled way. So I was telling Jake earlier, it would be like, having somebody go to IOP at NUWAY. They might have an individual therapist at Minnesota Trauma Institute. They might be living over at Stepping Stones. They have a PO in Ramsey County. And for those of you who have been on the front lines for a while, that's a lot of phone calls. What we do is try to move the communication out of the fax, out of the phone calls after hours, real time. So we're not asking somebody, 60 times what their first and last names are. We don't have to do, tell us about your trauma history for the 17th time in the past 3 months. So we're really, really excited about what we're working on and really grateful for the partnership of NUWAY and for a lot of the organizations that we have here in attendance. I'll be around if people have questions. I'm super excitable and really would love to share what we're working on and see if we can be helpful to y'all. And without further ado, I'll pass it over to Ken.
All right. Well, thank you both, Jake and Jordan. And thank you to everyone who's here today, both sitting in the room and out there in virtual reality. For those who may not know me, my name's Ken Roberts, and I work as the Chief Clinical Officer here at NUWAY, overseeing all those programs that Jake was talking about, plus a couple other things as well. So as was also mentioned, this is kind of a collaborative effort, and this is part 2 of a conceptualization that I had the pleasure of putting together with my colleague from your path, Dr. DeLisi. And I'm going to try and follow up on some of the good stuff that he shared with us and focus on kind of the next step about, okay, it's good that we know the why and, what's the how, what are the interventions that we want to apply. And so I need my IT guy because I'm changing the screens and not advancing my slides. All right. So as titled ABCs, really what we're talking about here is applied strategies for changing behavior for individuals dealing with co-occurring substance use disorder and trauma. And we know the prevalence of trauma in the substance use disorder space, and I'll certainly talk a little bit about that. Because you're getting some CEUs today, I had to provide some learning objectives. So this is kind of our roadmap to the talk today. We're going to make sure we understand the principles of delivering trauma-informed care. We're going to take a look at what that might look like from an organizational or setting standpoint. I really want to focus a little bit on utilization of the ACE screener today for adverse childhood experiences. But then really kind of towards the back end, talk about those key clinical factors relevant in treating both substance use disorder and trauma in the treatment setting, and try and, formulate some skills and strategies that are going to be useful for everyone doing the daily work out there, both in your individual and your group settings. So, again, thanks to Dr. DeLisi, who gave us a really robust overview of the neuroscience and the biology that go on in this co-occurring combination. I think that was just a great foundational understanding of the why, what's going on in the brain and what's going on in the body. But when we see those concepts walk into our treatment centers and into our group rooms as living, breathing individuals, we've got to have the tools to be able to work with them. So I will note, unlike my predecessor in talk 1, I am not a walker and talker. I need the safety blanket of my notes. So I'll be staying right here. I think I'm projecting okay, but if I'm not, please just tell me to speak up. There will be time for questions and answers at the end, but certainly if something comes up, just raise a hand and I'm happy to address it in the moment. All right. So, I think this quote is kind of a good summary to kick us off. Without understanding trauma, we're likely to misinterpret it when it manifests itself. So, we're going to take a look at what these behaviors look like in the practice setting. And oftentimes, as anyone who's doing daily clinical work knows, it's challenging. It may be unpleasant. It may not feel in the moment when we're trying to work through it like this person has a disorder or disease. It's just they're unpleasant. I'm being attacked. I'm feeling threatened. And so we want to try and equip ourselves with the tools to work through that. I think we're going to talk a lot today about trauma as a foundation for addiction. And, there's still a lot of debate exactly about these reciprocal relationships. Dr. Gabor Mate was mentioned in our first talk. He takes it all the way and basically says all addiction is rooted in some sort of trauma. Although he's pretty loose with his conceptualization of trauma. And I think what he is really meaning by that is in some sort of pain, which I do have some buy-in with, but it's not the way that we're going to define trauma today in terms of specifics. As Dr. DeLisi highlighted in part one, it probably isn't quite that simple. But what we do know for certain is that the level of trauma experiences, exposure, particularly developmentally, those adverse childhood experiences, which we'll be talking about shortly, and those trauma stressor disorders are highly overrepresented in substance use disorder treatment. And that the unhealthy cycle and behaviors of addiction often expose folks to perpetuating more trauma experiences, whether that's exposure to violent crime, sexual assault, or everything that goes with this opioid epidemic and the overdoses we're seeing, experiencing near death oneself, seeing friends die next to you due to overdose. So it goes both ways, and I don't think it much matters, which way you want to think about it. It's what do we do about it to help people get better. So here is how the Centers for Disease Control define trauma: physical, cognitive, and emotional response caused by a traumatic event, series event, or set of circumstances experienced as harmful or life-threatening. I want you to kind of mentally underline that experience, and I'll touch on that again. Trauma is so individual. But for those of you who've seen me talk about this sometimes before, this painting, which is fairly famous, called The Scream, is one I like to include a lot because I think to me it just captures that feeling which people dealing with unresolved trauma often have: confusion, isolation, fear, and pain. So there are three different categories for trauma. Acute is going to be that single isolated incident, a one-time event. Chronic is going to be ongoing exposure to the same type of event. And then complex, which is oftentimes where we think about that developmental trauma, is going to be exposure to multiple types of events that may or may not be related. So there at the top is the part I really want to emphasize in this construct, the 3 E's. It takes an event of that sort, which makes us feel threatened, to actually kick off the cycle. But there in the middle is that idea of how this is experienced, right? And what the effect is on the individual who experiences it. So if we were all riding on the same bus or train and we're in a crash, we could all walk away from that with very different experiences. Some of us might say, dang, that sucked. Some of us might be kind of shaky and not be sleeping well and feel a little anxious or on edge, but in a week or two, start to feel better and be like, wow, I dodged a bullet. And then some of us might continue to have that invade our thoughts, to make us feel uneasy. And it's when those symptoms are not resolving for an individual and impacting their function that we're starting to talk about diagnosable trauma or stressor disorders. Can we remove the allow recording, Jim? There we go. All right. So Again, reviewing a little bit about what we heard from Dr. DeLisi, what we want to be aware of as part of this talk is that trauma stressor response. I think at this point, most people have at least some idea of that concept of a fight or flight response. Although now, depending on who you ask, there are actually 4 to 7 ways that that is categorized. Commonly now you hear fight, flight, freeze, and fawn added to that as well. And then some really new categories, fright, flag, and faint. The basic construct of all of those is that that is how our brain and our body are hardwired to respond to danger or a threat. And so what we want to think about is this is the way that our body is actually set up to protect us from danger. And that is a good thing. So, you know, if a bear ran through that door right now into this room, hopefully we would all take actions to protect ourselves, right? We're wired to do that. But as the term amygdala hijack, I think, very colorfully reflects, in order for that to happen, our brain has to do things differently than it normally would. And so when we are faced with danger, the amygdala, which is kind of like the smoke alarm of our body, right? It detects the danger, is going to kick in and initiate the series of events that you can see here on the screen. And the really important thing to think about is that when that is going on, our ability to think, that executive function in the frontal cortex, is basically going offline. Again, in the short term and in the moment, that's probably a good thing. If I was standing debating what should I do and that bear was coming towards me, I might not survive. The problem that we run into with unresolved trauma is that that process is being reinitiated over and over. So the smoke alarm, the fire alarm is being triggered even though there is no danger. And that is creating levels of toxic stress in the body because the body is not meant to sustain this response. And so that has the potential to cause all sorts of physical health issues. And that's also the perpetuator of all of the symptomology that we're going to talk to. I think this is really important to talk about in our co-occurring population because it has the potential to be a trigger for a substance use relapse. But this process also mirrors in many ways what our clients or patients are experiencing when they are exposed to substance use triggers. Again, we've heard that story, like my body just went and did it. I didn't know what I was doing, right? So there's a lot of parallel here that it's important to understand and to help our clients or patients understand as well. So here's a little matrix, which I'm sure will look familiar to anyone doing work with this population. Symptoms of anxiety and depression are certainly some of the most common aspects of underlying trauma and some of the most common diagnosis that we see in our substance use population. But they can be very easily misinterpreted as standalone conditions. In fact, if you look at all of the symptoms up on this screen, we could easily point to other related reasons or conditions. But if underlying trauma is the foundation for these symptoms, then if we don't resolve that underlying trauma, we're not going to be able to provide that symptom relief. So these are just words on a slide. Let's think about what that actually looks like when folks are showing up in front of us. What do we see? Well, I'm guessing that any number of these behavioral presentations may look familiar to you. Inability to concentrate, aggressive behavior. Certainly substance use is the reason we're seeing all of the folks in our settings, but we're also hearing a lot about how the body keeps the score. So Bessel van der Kolk, kind of the godfather of really understanding trauma, wrote a book of just that name. And if you haven't read it, I highly recommend you do. So this is kind of the balance, right? That unresolved trauma is sitting in the body, causing a lot of somatic issues, which again can be misconstrued for other things, but also perpetuating some of this difficult or challenging behavior that we're going to have to deal with in practice. So how do we do that? Well, I'm going to start at the highest level of how I think we need to address this, and that is the idea of trauma-informed care. So we hear this term all of the time, but I want to be sure we're clear on what it really represents. This is the basic framework of trauma-informed care, the 4 R's, if you were. Realizing the widespread impact of trauma and paths for recovery, recognizing signs and symptoms when it is presenting, and probably the most important part and what we're trying to get at today is responding to that by integrating strategies and interventions. So it's not just clinical skills, it's policy, it's setting, it's a whole package. And all of that is going towards resisting re-traumatization. So I'm kind of focusing on the client intervention part today, but please, as we're talking through this, be aware that trauma-informed care is just as much about staff. It's about creating a safe environment for everyone. And what we know is there's a lot of lived experience in the field. So it's just as important for us as professionals to be taking care of ourselves in order to provide care for others. So even for organizations who are committed to these concepts, there's just going to be a constant need for ongoing assessment. We can do an initial assessment and decide what changes we want to make, but it's not a one and done thing. It's a feedback loop that needs to keep occurring because situations keep evolving and team members come and go, clients come and go. So it's not just, yes, we did an assessment, we made some changes, we're trauma informed. It's a living, breathing sort of experience. And so, as I mentioned, that central component is how do we create the safest environment for all? Well, the only way that we're actually going to get there is if everyone is involved. So that means buy-in at the top from leadership. That means cooperation and collaboration among staff members at all levels of the care continuum. And certainly it means that our clients or patients have to have a voice. So I didn't come to this talk today prepared with this story because it just happened last night and it was a super unfortunate one. But one of our programs was vandalized to an extreme degree last night. And so I got a call late at night from our staff, and we had to talk through how are we going to manage this situation for our staff and our clients in the morning. Walking into a building where multiple windows have been busted out, graffiti, kind of, an unhealthy environment in terms of safety. And so, as kind of a point of this being a team sport, the response from everyone in our organization was phenomenal, from the top to the bottom in terms of departments, our maintenance staff. If they're out there listening, our vice president of outpatient services, Heather, that program supervisor, Aga, they worked together and came this morning with a plan, and we were able to respond in a way that made that space feel safe and then normalize the day for clients. And, I kind of thought it was a coin flip when I drove out there today, and I was just so pleased at the response that we are able to put together in such a short time and that we are able to keep care going for clients today. So that's kind of the underlying idea of what we're talking about here. But what does this look like kind of in its totality? These are the components that are really critical when we think about what does this look like? And it starts from the very beginning. The first contact with our program agency services. Who is answering the phone? What are they saying? What have they been trained to say and how to handle that contact? What does the physical environment look like? There has been robust study now on all kinds of areas of how we can create a better trauma-informed environment. That goes from the colors on the walls to the lighting to the inclusion of plants. Plants are great. Plants have been shown to reduce depression and anxiety. Signage, all of the things that comprise the physical environment. And so any good trauma-informed care assessment is going to involve a walking of your facility. And if it's multiple facilities, walking all of them and understanding the context of what may make sense in one setting or community or geography may be completely inappropriate in another. And how do we make those adjustments? What sort of language is being used? I think we've come far enough now to understand that there's some pretty pejorative terms that used to be used commonly in the fields that we've kind of said, no, that doesn't feel good. Let's talk about things a different way. But that too is always an evolving process and has applicability in terms of certain areas or populations. Screening and assessment. I'm going to talk about ACE screening. I'm going to talk about a really cool new tool that I just learned about called a recovery rubric. And then, of course, the actual diagnosis. What are we doing? What are we learning at the outset to plan care? Really important. Standard reaction protocols. When we have behavioral events, what do we have in place about how to respond to those in a uniform way? It shouldn't be that Ken decides that you're kicked out and Monique says, no, come into my office, right? We've got to have a game plan and we have to have training that supports that. And then, of course, we actually have to have the tools. What sort of trauma-focused interventions are we going to use in a consistent way, which again is about training and commitment to the process. And then, as I've already mentioned, this is really all contingent on a big feedback loop. So what's working this week and what's working next week might not be working as well next month or next year. And we need to figure out how we're getting feedback from the client population about how they're experiencing their care and from staff at all levels about how they are experiencing our milieu and the work that they are doing so that they can feel comfortable and supported and safe and be effective. All right, so I think everyone has at least a minimal awareness at this point in the game about adverse childhood experiences. One of my points of emphasis for today is the prevalence and impact of ACEs in the substance use population. When we consider trauma-informed screening, I really advocate that ACE screening is probably one of the easiest, productive, and most useful tools that we can employ in a uniform way. Toxic stress is so prevalent when individuals have experienced this sort of developmental trauma. And I'm guessing everyone probably at least has some minimal awareness too, that there was a big landmark study back in the 90s that first brought all of this to our attention. You know, what we need to continue taking away from that is what it revealed about the longitudinal, the lifetime impact of these experiences on the people who underwent them. And it's on physical well-being, it's on mental well-being, it's on the behaviors, and it's ultimately about longevity of lifespan. So what does that look like? Well, of course, we've also added some additional categories called expanded ACEs that include that idea about generational or historical trauma and social context. But no matter which kind of constellation we're using, what's important is what those outcomes are if there aren't interventions somewhere along the way. So, we're looking at a greater risk for disrupted neurodevelopment, social, emotional, cognitive impairment, certainly engagement in risky and unhealthy behavior, and disease and disability. And what we also found out from that study is the more ACEs that one experiences, the greater the vulnerability for those conditions, including, of course, substance use and addiction and diagnosable trauma stressor disorders. Magic number in ACE screening, 4, right? Once we get to that level, you get, the fancy term is potentiating dose response, right? Meaning that your risk goes up in every single category because you have accrued more of those experiences. So this is a typical ACE screening tool. You can find it anywhere online. The ACE Aware website is a great resource for anything you want to know about study results, but also resources. So what we know now in terms of doing ACE screening is that best practice is to actually apply this screen, but only record the number that's given to you. In other words, clients may feel stigma or shame about admitting to these things. We don't need to look at this. All we need to know is what your number response is. And why is that important? Well, number one, we know if any of it has happened, and if it has, that should be a flag in our assessment process. But if we're seeing those higher numbers, a 3, a 4, a 5 and up, we do this consistently here at our organization, and we see scores that are oftentimes 5, 6, 7 on a consistent basis. That tells us about the level of toxicity and weight that clients are carrying into their experience and what we need to do about that. So Nadine Burke-Harris has been a huge champion of integrating ACE screening into primary care. If you haven't read her book, it's called The Deepest Well. I would highly recommend it. But some of these quotes directly from the book, I think really are a good way to underscore why I think this is so important. So yes, it's great clinical information for us to have on our side, but it also can start to be a way to help improve the way clients are seeing their experience and to empower them and motivate them and think differently in their recovery process. Because what we see for so many folks who are experiencing unresolved trauma, particularly when it reaches those diagnosable levels, PTSD in particular, is they don't understand what's going on in their brain and in their body. They don't like what they're doing, but they don't feel that they can stop or control it. So, why would you feel joy at realizing that you've had all these bad things happen to you? Well, I think one of the things that we can make part of our trauma-informed process is to really validate that you're here to tell me that you are a survivor, not a victim, right? But more importantly, I think it's this idea about once they have that information, they're able to see things in a different context. And some version of that statement, wait, I'm not crazy, I think is really the first step in that. So, per our requirements in Minnesota, we can't just do ACE screening. We've got to do a comprehensive assessment, and the flags on there will tell us we need to do a diagnostic assessment as well. And it's likely that we're going to see a number of these conditions. So just kind of reminding us, oftentimes I say trauma, you think PTSD. And yes, we're going to talk about PTSD is so much more prevalent in this population than the general public. But so are all of these other conditions. And so making sure we understand what we're dealing with, again, to be able to help empower our clients in their recovery process, but also to make sure that we are being mindful and respectful about any diagnosis as a heavy weight. And if we're going to be applying a label, let's be sure that we get it right. So this is the tool that I just mentioned and I'm really excited about. It's called the Trauma Recovery Rubric. If you're sitting in the room, there is a hard copy here for you to take. And I think Jake has already emailed this out to everyone in virtual land. Admittedly, I am just learning about this myself, and it's certainly way too dense to try and unpack here in our time. That's probably like another full presentation in and of itself. But I wanted you to have this to take with you. As you'll be able to see pretty quickly, there are seven recovery pathways and 6 domains within those. The great thing about this, it has been applied in multiple settings across different countries. And so it's been deemed through study to be a really reliable cross-cultural tool. And I think that's so important in the diverse population that we're dealing with. Just in having read this article literally a week ago and located this, I've started to think about how could we use it effectively for client education, for treatment planning, for progress monitoring. So, probably some work to do with my clinical team to think about that. I've included the link to where you can find the journal article and the outcomes from this. But it's a really interesting and I think potentially new tool. So tune back in probably in 6 months and I may have a lot more to say about this, but wanted to get it out here as part of this talk today. All right, so literally says right here on my paper, check the time. We're doing great. As I mentioned near the outset, right, we're still kind of not of all one mind on how we conceptualize the reciprocal relationships between these conditions. And again, I think that's okay. I think it's more important that we understand that there are connections and relations and that creates some reciprocal vulnerabilities that we really want to be aware of when we're conducting our clinical work in order to promote recovery for both conditions. So this is a construct that I actually just shared with our client population a week or 2 ago in lecture. So there may be some familiar elements to any of the NUWAY staff out there, but I've expanded it to factor in some of those clinical perspectives that are important to that side of the work. As I reminded the clients in that lecture, and will remind all of you as well, all of us are vulnerable to that silver bullet thinking. Like if I do this one thing, if I learn this modality, or if I do this intervention, we got this thing. Unfortunately, hopefully, as we already learned in talk number 1, addiction, trauma, and PTSD are not that simple. But I think this is a great little acronym to think more in terms of what are the building blocks that we need to put in foundationally to support recovery for clients dealing with these co-occurring conditions. And that structure is going to look different and be a little individualized for every single client because of their own individual experience. But I think there are some very general concepts here that are applicable for almost everyone. So that idea of community, that idea of health, and I'm really talking about physical health there. And then kind of where we'll really focus our attention on the back half here, education, skills, and services. What do we do to be helpful? So I think a lot of folks have seen this quote from Johann Hari at this point: the opposite of addiction is human connection. And Judith Lewis Herman says something similar about trauma, PTSD. Recovery can only take place within the context of relationships. It cannot occur in isolation. So for many of you, you're out there running a process group on a daily or regular basis. That is a heck of a good start. We're building a community right there. And when we have individuals coming in to do programming together, we're building more of a community. So the rest of our work from that perspective is to fill in the blanks as it is appropriate for each of those individual clients. And that might mean support groups. That might mean religious support. That might mean family. Any and all of the categories that you can think of and that I'm not naming are ways to build that sense of community, build a safety net. We need to remind them that they're not alone. and that they'll only benefit from building a support system. All right, so that's the C. The H is health. I think clients often find attending to physical health very easy to overlook, particularly in the beginning. But of course, it's a foundational component of recovery. Both substance use disorder and trauma frequently interrupt healthy habits in all of these basic categories. And so this is a great way of kind of, again, starting to build that foundation so that we can then implement some of these other interventions and that they can be received. If I'm sleep deprived, if I am not eating correctly, if I'm not getting regular exercise, my ability to be engaged and to participate is compromised. So we want to do the best we can in all of these areas. I'm sure all of your insurance partners are reminding you that a primary care physician is something they'd really like involved. But I don't need them to tell me that that's a useful thing as part of this process. And particularly for individuals in on the substance use disorder side, if medication assisted treatment is part of a way to assist them, we want to make sure that that's accessible and that we're coordinating care to build, again, that level of stability. Oftentimes, I like to think of the metaphor to share with clients or patients of, thinking of your body as a house. Right. And if you're stop and do an assessment right now, you're probably a fixer-upper at best and maybe even be a little ramshackle. So what do we need to do to, get you up to sail and have some curb appeal? Well, probably all of these things. Okay. So let's move on to thinking about kind of those concrete behavioral interventions that we can make. And here's kind of the underlying construct, which I think is parallel for both substance use and for trauma. The core is that underlying emotional pain. And the pattern is of avoiding that. So really fits well for this population. Substances are often the only way that clients have been able to manage their trauma symptoms. We're going to say, don't do that right now. So the potential for them to feel all of that even more is going to be there. And we need to think about how to manage that. So that's where we come in. That's what our work is helping to build tolerance instead of avoidance, right? And the only way to do that is practice, because the ultimate purpose is sustainable change. So we can't just dive into a silver bullet fancy thing that I want to try, like prolonged exposure therapy, right? Let's do some education and let's build some skills and let's think about those in a stage-matched, person-centered way. So again, notable that both of these kind of conceptualizations about recovery look amazingly similar, right? That first step in SUD, admit I have a problem, right? This isn't working. Trauma, same thing, acknowledging what's going on, and then working towards building that sense of safety and stability. We can't get to the work of processing and change if people are not feeling stable and safe. So we've got to go in stages. And then kind of that longer term longitudinal goal of how do we integrate those learning and those skills and the processing to provide that stable long-term recovery that can be maintained over time. Well, here's the E, education, right? And to me, education really equals empowerment. So we spend a lot of time already in SUD treatment doing education for our clients, and I think that's great. It's critical that we are providing specific education about the impact of trauma. And I think it's, useful to remember that just because I don't have trauma that has reached a diagnosable level, that doesn't mean that it isn't impacting me. And even if there is the rare client out there who has no trauma and doesn't even think that's a thing, learning about this is a great way to be part of the community and to support others who do, which is almost everyone. So making sure that we are helping them to learn how trauma impacts the brain and body, just like we've been talking about today, and that is reversible. There's hope. That behaviors and symptoms are normal reactions to very abnormal circumstances. If you have been living in a household where you experience multiple ACEs, you don't have any way of knowing that that isn't normal, because that's the only baseline that you have. So we really want to help to reframe that. And then kind of, again, just like with the ACE screening, emphasizing survivor, not victim. Hey, you're here. We can do something about this. You know, you've survived this far. Let's help you go further. And making sure that by creating that environment of safety and trust, that we can start to mitigate the shame and stigma which thrive in silence for both substance use and trauma. And that's a way to get at the idea that there is hope. So I would be really surprised if the majority of clinicians out there have not employed some, if not more, of these skills in your individual sessions and in your group settings already, right? Things like mindfulness, things like emotional awareness, things like self-soothing. So being able to manage impulses, to emotionally regulate, to be able to stay grounded when I am feeling triggered or unsettled. These are great in the individual setting, but they thrive in the group setting, right? Because that's where we can learn as a community and we can practice and run scenarios. And kind of, making sure that the backup plan for everyone is to think about what happens when even my skills that I've learned aren't working. Who do I need to go to? What is my crisis plan? I need to call my counselor. I need to call my peer support. I need to call my mom. It doesn't matter what your plan is, as long as it is a workable plan for you individually. So lots and lots of great resources out there, listed some here on this slide. Trauma skills groups, trauma focused curriculum are out there in wide number. There's one that I haven't included on here, which we like a lot here at NUWAY, called BRIGHT, which stands for Building Resilience for Individuals Through Trauma Education. Again, this is an opportunity to work in that group setting and to provide uniform tools for our clinicians and our clients so that they're getting the same materials and learning. I'm not here to sell you on any of these. What I will say is be sure that you're incorporating that feedback loop with your clinicians. Hey, this one works great. Hey, this one stinks. And then what are the clients saying about that? Hey, this is really useful, or geez, I hate this. Being willing to experiment and mix and match to find things that work, but having kind of that uniform baseline can be really, really important. And I think what that gets at in all of this is the importance, before we move into trying to do processing, is to really be thinking about the reciprocal triggers that go hand in hand between substance use and trauma. So internal, well, that's going to be emotional distress, thoughts, and memories. For substance use, that could be a using memory. For trauma, it's certainly going to be that intrusive thinking and memories of bad things that have happened, but then that perpetuates into those physical or somatic sensations as well. So what's going on up here and in here, right? What's happening on the outside, right? If I am coming to a group setting where there's a couple hundred people in the building on a daily basis and I have some unresolved trauma, I may feel anxious. I may feel unsafe. I may feel on edge. Certainly, despite coming to treatment, there is the opportunity often to go into the community And so, what are the things that are triggers, whether it be for substance use or your trauma, that we want to consider from that external perspective and from the environment itself. So this all comes back again to that idea of how do we create safety? How do we educate individuals about how they are experiencing these things? And what are the tools that we can give them to be sure that they have a chance of navigating that? Because it cuts both ways every time. Recurrence of my trauma symptoms puts me at vulnerability for a return to substance use. And dealing with my substance use triggers probably is going to then tick off some of those trauma triggers, and I'm elevated even more. Very challenging situation. So let's think about this. And what I really wanted to kind of focus on towards the back end here today is this idea of what do we want to do in that group setting? Because this is where so much of the work is being done. I don't know how many out there have been in my groups theory class over the years at one or both of the schools. If you have, you probably recognize this slide. Even if you hadn't and are doing group work, I would hope that this looks pretty familiar. So, these are Victor Yalom's 11 curative factors. He's the godfather of group therapy. But some of these are so fundamental to the work that we're talking about today that it's really important to recognize how we can tie these or link these in to the interventions that we want to try and do specific to substance use and trauma. I think the one that we can all point to almost immediately is universality. Well, hey, you're all here for this purpose already, right? So we're off to a good start. But things like being able to build social skills, develop interpersonal learning, certainly that installation of hope. And then I want to talk about in that group setting, what can we do to get to processing in a safe way that will be productive, but also won't develop that, kind of contagion or triggers for others. So I look around the programs I oversee and I see great clinicians doing creative and innovative group work every day. I also know as a clinician and professional myself that there is always room for further innovation and improvement. Even when you go into group with your best plan, that seldom gets followed. And so how do we make the adjustments? But what are the themes or building blocks that we need and want to work with on a regular basis to get results for clients, particularly around these two conditions? So, the most basic thing, right? Group 101. As a clinician, I'm responsible for creating a holding environment for the safety of my group and for building trust. And one of the best foundational ways to do that is to attend to your norms. Do we read the group norms on a regular basis? Do we have them? Do they change if someone has to sub in for me because I'm out today? These are all the pain points. I can see heads nodding in this room. I'm sure they are at desks out there. And it seems so basic and so simple that I hesitated about whether I wanted to put it on the slide. And then I said, of course I do, because we should never forget this. Our training director in the back is giving me the thumbs up. I guess I did well. Sometimes challenging in the early going, and then also just based on, who you're working with in group, but really honing your skills in helping to link people to one another during processing. So, I've kind of processed this out to acknowledge that these skills are kind of aligned with those different phases of stage recovery, right, for both of these conditions. So linking gives individuals a chance to understand, hey, this is going on with someone else too, right? And to acknowledge their own condition. You don't have to stay in big group all the time. Dyads, triads, breaking things out, getting people to work in different constellations. If I'm the new guy in a group of 15 today, I probably am scared to death to speak up and say something. But if you pair me up with Dr. DeLisi for a little one-to-one, maybe that's going to create a different dynamic. And then we can bring that back to group. So that small group work is really a great place for processing, but it's also a great place to do some of that skill building that I referenced earlier, right? Let's work on this. Let's role play this. Always being careful to, keep it within parameters that are going to feel safe for your group. Using your basic clinical skills, motivational interviewing, and cognitive behavioral therapy. These are the staples for SUD. CBT is one of the staples for that more intensive trauma work as well. So being sure that you're incorporating those as tools for processing and integration, challenging that negative thinking that come with substance use and trauma, and being able to work on how do we correct that. And then, the part that Yalom loves and that is the hardest to learn and sustain, how do I work in the here and now? We don't need to hear war stories. Hey, what's going on right now? How is the group experiencing this right now? Why is that important? Well, that's the catalyst for what he fancily terms process illumination. And that just means to me, learning some stuff from one another, right? So that's where we're really going to get that integration and that emotional regulation and that growth and that learning. Hardest task for the group clinician to do on a consistent basis. You think you're doing it and then you're not. It's there and it's gone, right? But making a commitment to working in the here and now as often as you can. And then I didn't put it on the slide, but I did want to acknowledge just with the population that we're seeing now, continued post-pandemic fallout, all of the things, acuity levels are sky high. And so are the behaviors. So, this is where I love to take a quiz. Who loves confrontation? Who loves conflict? It's Minnesota, so you don't get any takers. But the idea is, right, nobody loves it, but it's going to happen, right? And so making sure we are also prepared, working on de-escalation skills that aren't specific to substance use or trauma, that are just, behavioral management, but making sure we're prepared. And I think that's about supporting one another and about continued training as well. So that's a whole nother training, which I know that we do. So I'm going to finish up today just mentioning PTSD specifically because I do see this as the most challenging comorbidity on this spectrum. And, PTSD, I think, is that level of highest unresolved trauma impacting function. It's also rampant in our population. So normal rates in the population, as you can see up there, I guess it's not, it says 8 million. Normal rate in the population is about 8%. Unfortunately, the risk for women is double that of men. But depending on which literature you read, in the substance use disorder population, it's nearly triple that. So it's something we're going to be seeing on a regular basis. Knowing what that looks like, there's the 4 pillars, right? That intrusive negative thinking, that persistent change in cognition and mood, that sense of being aroused or reactive. So the startle response, the not feeling safe, all those kind of things. And then the hallmark and what ties right into usually the presentation is avoidance. And again, substance use is frequently the way that avoidance is being achieved. So when we get to this point, we're talking about that last S, which is the need for some additional services. We can do all of the stuff in group, but one of the things that we don't ever want to do unless you're in a very focused or specific group scenario is to try and process individual trauma. That presents a sense of potential lack of safety for the group, emotional contagion, all of that stuff. So when we're talking about PTSD in particular, we want to look at some of those evidence-based therapies as our tools. I've put up the 4 that are what in the field are considered the gold standard, the four big evidence-based ones. And all evidence-based means is they've been studied a lot and shown to work. EMDR and ART are both eye movement based. Cognitive processing therapy, or CPT, and prolonged exposure, or PE, both have that CBT foundation, but all of them incorporate that concept and utilization of exposure as a tool in different ways in each therapy. But exposure has been to be kind of that foundational key to helping to resolve trauma. I'm trained in two of these and happy to talk about that more after for anyone who's interested. I'll also note that there are a host of others that show great efficacy and are promising new therapies, trauma-focused CBT, brain spotting, all of the trauma-focused yoga, animal-assisted therapy, equine, pet, dog, etc. So, I'm not here to sell anyone on, hey, it's got to be one of these, but I think it's important that we make sure our clients are informed about, hey, these are the gold standards, and that we help to find the best individual fit for the person that we're trying to help. So if you, aren't trained in one of these yourself, or we don't have the capacity internally, then knowing what's going on in the community and knowing where we can find these resources is pretty important. So here we are. We made it all the way to the end. One of the things that I think about with change is even when it's positive, it's anxiety producing and it's hard. So we know that treatment can and does make a difference. It's a life or death difference for a lot of the folks we're serving. But unfortunately, all of these things I've talked about were new at one point and didn't necessarily get adopted right away, right? So it's easy to fall into our comfort level, right? And to become complacent. But I think what I wanted to end today with is, whatever has resonated with you today as you think about this population, think about what are the changes that you might want to make to enhance your capacity. And, I can't talk you into that. So I'm going to go to my favorite leadership guru, Simon Sinek, who talks about the golden circle. And at the center of the golden circle is the why. Knowing why you come in and do what you do every day. If you have chosen to serve this population, you probably got a good why. I didn't mention it when the ACEs screening came up, but it's probably useful to know your own ACE score as well, because that might be part of who you are as a professional. I know mine's a 4, right? And that has helped to inform me in some things that I've needed to do to stay a professional, right? So think about what your why is, right? And hopefully that's the catalyst for making any of the changes that you want to make in enhancing your clinical practice. All right. I don't know where we are time-wise, but hopefully close to being done on time. 3 minutes over. I'm going to blame that on Jake and Jordan. Thank you to everyone who's here. Thank you, everyone. We have time for questions or yeah. So if there's questions in the room or if there's questions in the chat, I'm happy to do that. And I also understand it's late in the afternoon. So if you want to get the heck out of here, I'll hang around for as long as anyone wants. Yes.
I have a few that came in during the chat, during the presentation. Mary says, wouldn't a parent being very ill or dying count as an ACE? Couldn't there be other ACEs not on the chart, such as a major car accident, crime, fire, etc.?
Yeah, so the question is it possible for there to be other ACEs that weren't included in that construct of 10? And I think the answer is yes, because we've looked at expanded ACEs before, but the idea is these were kind of the foundational constructs that were used for study. So some of the examples, like potentially, a car crash or a loss. One thing that I didn't really touch on, there is so much overlap between grief and trauma often, that sometimes those get tricky to sort out and have to be evaluated very carefully. So yeah, you know, you don't have to have one of those categories if something bad happened in your childhood to know that we have the potential for unresolved trauma. And I think those are the things that, you know, even if I have an ACE score reported of 0, when we are doing the assessments, hopefully these things will come out as well and we can attend to them.
I have another one from Jill. Do you use the description and components of recovery capital?
Could you?
This came in during when you were going over the health section.
Yeah, so the term recovery capital, I think, is a really great term. And, you know, there's actually some scales and screeners that we use now for monitoring or evaluating recovery capital as well. I think that has really kind of emerged alongside the idea of more use of lived experience and peer services in the field. And recovery capital, I think, is just a great and different lens for evaluating what are the resources that each individual has available to them as part of their recovery. Kind of right alongside that, the idea of post-traumatic growth, I think is one to think about as well. So great terms to work in.
The last one is, does NUWAY use peer service or peer recovery coaches or family peer recovery coaches?
We do use peer coaches that are embedded in programs. So they are site-based and work with clients and individuals there. So that's typically a client-focused service, not a family-focused service. But I know that we have resources that we work with in the community and refer to for family services as well.